Three experts in the field, Dr. Vicari, Professor Gagliardi, and Dr. Karminov. I will give the floor right away to Dr. Vicari, who is going to start his contribution, his paper on neurocognitive and behavioral aspects.
Thank you, Dr. Zorzi, for your introduction. Thank you for your invitation. I would like to thank President Torlonia, who wanted to organize this important meeting that marks a step forward in the knowledge of Williams syndrome and is an opportunity to meet people that over the years went through the same pathway. Williams syndrome is born with us, with this generation of professionals. I have 20 minutes at my disposal, and I have to talk about neurocognitive aspect. And I went down memory lane a little bit, as you could understand from my introduction. And I wanted to go back to the history of Williams syndrome over these years. And we've seen it this morning with the first description that dates back to the late 1950s, between the late 50s and 1961, with the first description by Williams. So it's Williams syndrome is my same age in a certain way. So the interest for this syndrome rapidly grew over the years. And a leap forward is marked in the mid-1990s because, as you heard, there is the description, the genetic cause. But when we started to deal with Williams syndrome, we didn't know yet what the actual cause, what the gene alteration was that marked the syndrome, and it was unknown still. With reference to this syndrome, there has been a lot of interest, despite the fact that this is a rare syndrome, and this is surprising. I'm going to try and tell you what the reasons are for this interest that is still present for Williams syndrome. So, over the history of Williams syndrome, there is a wide timeline from the first formal description, which was not actually the first one of the syndrome, up until the late 1980s, when especially the people who do my job, so neurocognitivists, approach Williams syndrome with renewed interest. And we start describing, with reference to the topic of this session, the neuropsychological aspects. Three main aspects are taken into consideration, namely the presence of an intellectual disability in the first years when the cognitive profiles of young children and adults was traced. Mental delay, mental retardation was a constant factor. There's also a feature of extroverted behavior that is one of the typical features of this syndrome, and a typical cognitive profile. Well, as I was saying, there was a great interest in the syndrome starting from the 1980s, especially from neuropsychologists, but even more so on the part of linguists, psycholinguists, because Williams syndrome seemed to be strongly characterized by a particularly evolved or exceptional linguistic pattern in the presence of mental retardation. And this was surprising because it highlighted, well, it was almost a natural example of a strong theory, a theory that had a strong impact in those years on the presence of an important dissociation between cognition and language. Cognition and language, and it's part of Chomsky's theory, cognition and language are completely separate. So finding a population where the language was evolved in presence of mental retardation was the proof, seemed to be the proof. The history changes when the gene alteration, namely the microdeletion of the chromosome 7, and we heard about it this morning. So we start having sure diagnoses. So a little over 20 years ago, the diagnosis was only clinical. We did not have any objective instrument to diagnose Williams syndrome. And this explains the considerable increase in the publications, as you saw it in the first slide, on Williams syndrome. And in those years, there's a foundation of the Italian Williams Syndrome Association. So there is a strengthening of an Italian study movement on the syndrome, which strongly characterized literature throughout the world. I must say that this adventure, today many of the main characters, such as Letizia Sabatini, Virginia Volterra, Maria Cristina Caselli, the colleagues are not here, but they were very highly committed in the description of the psychological profile of Williams syndrome. So there's the start of this collaboration between the group of Virginia, Cristina, and myself with the San Diego group, Elizabeth Bates, but Ursula Bellugi, that is strongly oriented, ideally oriented between a sharp dissociation between cognition and language, as I was saying earlier. So there's this collaboration, and then we started publishing data that are contrasting with the Bellugi data. And so we were always invited in San Diego, but then after this we were not invited not so often anymore. So, of course, we still collaborate. Ursula Bellugi participated 20 years ago at the first conference on Williams syndrome in Rome. So we start getting to know the syndrome better. On the top right, you can see that the estimates were, in terms of the incidence of the sort of one every 20,000 or one every 50,000 people. So it was very difficult to make a diagnosis. And this incidence went down, not because more people are born with it, but because we've gotten better in recognizing it. We characterize these three areas I was talking to you about earlier on. So we start understanding that the intellectual disability, and we called it, it's mild to average mental retardation, which is a little bit with compromised aspects because and we start finding dissociations. The group that I was mentioning earlier, a typically Italian group, start describing dissociations with reference to language organization and cognitive abilities, and also with reference to the behavioral aspects. People start to understand that the main feature is hypersociability and an apparently empathic behavior on the part of the patients. So there is a greater, an increasingly detailed description of the disease and its symptom. These are the discovery years. As the first book that was strongly promoted by the Williams Syndrome Association, in particular Leopoldo Torlonia, and the activities. The main activity was carried out by Aldo Giannotti, whom we can never thank enough for all his activities in favor of Williams syndrome in those years. And we more markedly describe the features. As Italian is a complex language compared with English, it's rich in grammatical aspects. So we describe the fact that some aspects of the language are not so much evolved, but they're predictable, considering the mental age and the overall cognitive ability. So we deny the dissociation that was so much emphasized of compromised cognitive ability and language that is spared in these patients. And we start describing some visual spatial abilities and there are not language difficulties, but the difficulty in visual perception of spaces. So we start understanding Williams syndromes from a cognitive viewpoint. So we start with targeted rehabilitation processes. So we start thinking that Williams syndrome has to have a typical and targeted pathway. So the golden years are the ones of the second half of the 1990s, where there's a flourishing of literature. There are lots of studies that are conducted all over the world in a specific way for the neuropsychological aspects and rehabilitation projects. The estimates on the incidence goes down from 1 to every 20,000 to 1 every 10,000. So even the pediatricians, the general pediatricians, are starting to know the syndrome. And I'm saying this for those parents who have just become involved in this adventure. The history has been a very difficult one, with great contrasts with colleagues that were not used to recognizing these children and that they generically classified as children with mental retardation. And the more we study, the more we realize that the linguistic and cognitive profile of these children is marked by great atypical factors. So there is the language works better for some aspects, and for other aspects it works less well, so to speak. And I'm quoting Professor Kamilov Smith, who gave us the honor of being present here, and so the cognitive profiles is characterized by peaks and valleys, and so there, and some aspects of language are particularly evolved and some are particularly impaired. So the more we know about the disease, the more complex and articulated it becomes. And not only with reference to language, but also with reference to visual spatial activities, there are abilities. There are the ability to recognize shapes and colors. For example, face recognition is an ability that Williams' children seem to have. I'm generalizing now, but of course there's a great variability. But the ability to process spatial elements, namely movement, that is so important to be oriented in a city or to cross the street, is an aspect that is particularly, in general, particularly compromised. Over the following years, and we are seeing these years, we consolidate our knowledge and we enter into the specifics, and we enter into the details and the estimates about the incidence. We are starting to talk about one case every 7,500. We started 20, 30 years ago with one every 50,000. So this highlights once again the diagnostic capabilities that we have, also thanks to the identification of the deletion of the genes on the 7th chromosome. A new edition of the book comes out, and all the Italian colleagues who are involved in the study of the syndrome are involved in the book. So the input given by the association was very important. And so we start understanding how the cognitive and language cognition is correlated with the brain structuring. So we start understanding that the specific gene alteration, and there was a slide this morning that was very eloquent, and this gene alteration is translated into the organization of neuronal activity, so the brain organization. And Chiara Gagliardi, who's going to speak afterwards, will clarify this aspect better than I can do. And so we start making some correlation between brain organization and behavior. At the same time, we start understanding that these behavioral aspects, initially described as marked by hypersociability and by empathic behavior, are actually, they may also hide a psychiatric comorbidities, so to reach some psychiatric disorders that deserve our attention. So we are able to enter into greater details all the time. So we start seeing specific aspects that mark our treatment. So this slide summarizes the language profile of small children under 8 years of age, of chronological age, so even smaller in terms of mental age, in neuro, on the left side, the neuro-language side, and the typical profile of adolescents and young adults. These are the same language tests. You see how the two lines refer to different populations, Williams syndrome and Down syndrome children. Initially, as you can see, the differences that are there are minimal, and these differences become more evident and consolidate over the course of development. Development becomes the element that somehow sculpts the language and cognitive capabilities. This special functioning in Williams syndrome is not present at birth. It's something that is structured and organized over the years, over the time of development. And this should make us even stronger in claiming the need to have early intervention, because this fate, which is strongly marked by the biological and genetic base, is interacting with environmental stimulation. So we know that an early intervention may certainly not upset or recover or reverse this fate, but it can change its trajectory, making them less marked and less evident. Over these last few years, we are studying the correlation that there is between behavior and brain organization. In these images, I'll show you how for certain abilities may be correlated with certain special areas. On the left side, you have some language tests, and on the right side, you have some visual spatial abilities. So we're starting to understand and describe the important correlation that there is between gene organization and brain representation and behavioral and cognitive expression that is so typical of Williams syndrome. As I was saying, there is interest raising that was an aspect that was neglected in the early years. So maybe Williams syndrome patient may have a comorbidity complex. So it's a disorder associated with another disorder. Williams syndrome may be associated sometimes with a relatively high frequency, higher than in the general population, to other disorders. In particular, psychiatric disorder, ADHD, as was recalled this morning, reaches 20%. Consider that in the general population, it reaches at most 5%, or mood disorders that in their expression may reach depression up to 14% of the cases. Consider that in the general population, the estimates that are maybe exaggerated talk about 8% of adolescents with mood disorders and anxiety disorders that reach 50% of the cases. So too often these aspects are neglected, untreated, and classified solely, as I was saying this morning in my final intervention, characterized as expression of the syndrome itself. So somehow it's as if they weren't worthy to be treated. I would like to underline the last line. We have a more than 10% of psychotic disorders that seems to be typical of the adult age. And in our experience, this is generally not treated. But there are specific protocols for psychotic episodes intervention that may interrupt the disorder itself and prevent it from becoming a chronic condition, which means a further compromising of the general functioning of the children with Williams syndrome. I am being told that I have to start to conclude my intervention. I will be doing so in 5 minutes. So what's brewing up these days? I'm not able to present to you everything that is being done throughout the world. I can tell you what we do within our laboratory. Well, we try to specify better the psychological profiles and the effects that this may have in their daily lives, especially in the children and adolescents and young young adults. And we tried to understand whether the possible psychiatric comorbidities, especially anxiety, may affect the intellectual and social functioning of children and young adults affected by Williams syndrome. There's a series of studies here that inform us about the learning capabilities and memory capabilities. Especially, we know with a certain clarity that Williams children are at an advantage when they have to learn a procedure. They learn by observing, so they observe what another person, an adult or a companion, can do for them. And this suggests school learning strategies that may be important. It's much more effective to learn by observing rather than by trial and error with Williams syndrome's children. Also, in terms of long-term memory, the knowledge baggage that accompanies us throughout our lives, there are some strategies connected with repetition of stimuli, but we also know that some abilities, I think that Chiara Gagliardi will talk about them, like the executive functions, the ones that we define as specific to human beings and that have to do with the most evolved area, the frontal area of the human brain, and they are dissociated. There are some abilities of this kind that are compromised, and this can have an impact. We have attention deficit and working memory deficits that lead to ADHD, and this would lead to drug treatment even in the early years without without waiting for the adulthood to set on. So there is already available a drug treatment that is readily available. The quality of the capability of understanding the action patterns of Williams syndrome is a very promising aspect. On the right side column, you see the results of a recent study with the Rizzolatti group. Rizzolatti is world famous for the mirror neuron thing, and we identify them in Williams kids, and some difficulties seem to be there in understanding other people's actions, and this is a challenge for the forthcoming year to improve their integration within the group. So what can be the relationship between behavioral and psychiatric aspects and the cognitive functioning? As you have seen, anxiety is very frequently associated, and we have seen that in children and adults where an anxiety disorder is present, in general, we have poor social abilities. There's a worse neuropsychological profile, and paradoxically, it's associated with a higher IQ. This means that Williams syndrome children, unlike the general populations that are more brilliant from a general cognitive viewpoint, they more frequently show a concomitant anxiety. It's as if greater awareness can be connected with a sense of inadequacy, so difficulty and concern with reference to the requests that the outside world can make. But this highlights the need to be alert as doctors, and in particular as a child neuropsychiatrist, of this possible comorbidity and intervene, because it can be treated. Waiting and delaying over the years, over the decades, an intervention on these aspects may be damaging and difficult to recover. I'm saying some things that we ourselves, I'm not talking as a dad, but as a group at the Bambin Gesù, we underestimated them because we didn't know them. As the history I mentioned serves to make you understand how much awareness has risen in approaching the children, the families, adults, young adults with WS. What are other prospects? And I would like to conclude now, and I apologize for stealing some minutes from the other speakers. Well, we would like to associate and to carry out a diagnosis of Williams syndrome that is personalized more and more, and have an early specific diagnosis, identification of genetic markers for the specific children, which is a future prospect not only for Williams syndrome, and this is happening for autism as well, which is another very frequent and more dramatic than Williams syndrome. It is possible to design some targeted rehabilitation and drug interventions that are strongly biased on the gene and personal features of the person with the Williams syndrome, and studies are very promising. These studies were conducted recently, and they say that it is possible to correlate a specific gene profile with a just as precise cognitive profile, and this will be the commitment for the next few years. It's important to identify the weaknesses of the Williams syndrome patients, but it's even more important to identify the strengths. So far, I've talked to you about a peaks and valleys profile. There are some abilities and skills that we can strengthen to favor the greater integration of these kids, but also a quality of life and a possible happiness, because happiness is possible even if you are born with Williams syndrome. And I would like to thanking all my collaborators. This is the big family of the child neuropsychiatry unit at the Bambin Gesù. We have nurses, psychologists, researchers, doctors, speech therapists, and secretaries. Those who came to us may recognize some of them in this list. Thank you so much.
Grazie.
Thank you, Stefano Vicari.